So that's working. Okay, so lateral medullary syndrome called Wallenberg. Let's draw in our arteries here. Still cranial nerve number 12 there. So here's your vertebral artery. And what we saw on the big overview picture was that there's a pair of arteries coming off the right and left vertebral artery to supply the posterior inferior surface of the cerebellum. And we said that was pica. So lateral medullary syndrome is a disruption of pica. And here we're looking at left lateral medullary, so we're going to look at left side. So okay. So the territory for pica is the lateral medulla. And here I'm going to just delineate the part that's associated here. So all of this region is going to be affected, and all the tracts and all the nuclei are also affected. So if, let's say, the inferior cerebellar peduncle was affected, what kinds of signs and symptoms would you expect the patient to display? Any thoughts? General word, ataxia. Right, the person's going to present with ataxia here. If the nucleus ambiguus is affected, what are they going to have trouble doing? Cranial nerve 9 and 10, associated with what kind of function? Swallowing, good, swallowing function. They're going to have trouble swallowing. Okay, spinal nucleus of trigeminal nerve is affected. Trouble with facial sensation, yeah. And here's the sympathetic tract is going to be affected. So that person's going to present with Horner syndrome, good. And then spinothalamic tract is affected. Present with loss of pain, temperature, crude touch. Okay, those are all symptoms of lateral medullary syndrome, which is also known as Wallenberg, and that's due to the disruption of pica. And there's a saying that Wallenberg is pretty popular one that you might see in your clinical future. And the thing you can remember is never pica, I'm just going to say pica, or never pick a small-eyed due to the disruption of the sympathetic tract, hoarse voice that wobbles and can't swallow. So, easy way to remember. Pica, lateral medullary syndrome. Never pick a small-eyed horse that wobbles and can't swallow. It wobbles because the inferior cerebellar peduncle is affected, can't swallow, and has a hoarse voice, so it's nucleus ambiguous, as well as the sympathetic tract gives them a small eye. Okay, so just something to remember. Never pick a small-eyed horse that wobbles and can't swallow. Questions about that? Does it make sense? So if you know the artery, you know the cranial nerves that are involved, you know what's in the middle, you can predict signs and symptoms, patient presentation. All right, moving on from lateral medullary, let's go to medial pontine syndrome. That's the cross section here. So that was pica. Yes. Okay, then this is going to be left medial pontine syndrome. Again, here's your pons, a cross-section of the pons. We've seen this previously when we were looking at the brainstem overview. This is going to be ventral. This is going to be dorsal. Now, it's just a matter of going through and labeling a few things. Bless you. And this is going to be part of the ventricular system here. What part of the ventricular system is in the pons? Does anybody remember? Perfect. That's your fourth ventricle. Okay. Thinking about cranial nerves that are in the pons, the first one's going to be most medial. Here, cranial nerve nuclei. This is cranial nerve number 6. That's most medial. Okay. And then cranial nerve that's a little bit more lateral. The next lateral is going to be cranial nerve number 7. It's going to be your facial. Okay. Thinking about still being really, really medial, these little tracts here are involved in producing a conjugate gaze. So they link all the extraocular eye muscles together with the vestibular nucleus. Does anybody remember what this is? That's your MLF. Good. All right. Now, thinking about other nuclei that are involved with cranial nerves, there's this guy here that usually make his little kite and the associated nucleus with it. Okay, this is going to be cranial nerve 8 nucleus. This is vestibulocochlear. So vestibular on the bottom and cochlear just above. Okay, always sitting here, most ventral. Yep, this is your corticospinal tract. Okay, here's the small little tract that, if disrupted, causes Horner syndrome. We talked about that today. That's your sympathetic tract. Okay. Usually somewhere around the sympathetic tract, you have this tract, spinal thalamic tract. And here, in the medulla, it's going up and down, or it looks like it's going up and down. Here in the pons, it's just migrated a little bit and changed position. It's still an elongated tract. This is your medial lemniscus. Okay, one more we haven't labeled yet is going to be, here's your spinal nucleus or trigeminal. There's going to be, I had to draw, here's my midline, just going to put my middle in, separate right from left halves. way back here. It's going to be the conduit that connects the brainstem with the cerebellum, or the pons with the cerebellum that's most inferior. This is going to be your inferior cerebellar peduncle. Going up a little bit higher. Let's go ahead and say this whole area on the outside here is the largest of the peduncles that you're going to see. And that's your middle cerebellar peduncle. And there's just one more peduncle that we haven't labeled yet, and that's going to be your superior, all the way out here. It's going up and down. Superior cerebral. Nothing new there, just labeling what we've talked about before. Going through, and we know that the main artery coming up the middle here, through the middle of the pons, is going to be your basilar artery, and it's going to sit right here. And coming off the basilar artery, you're going to have your little pontine arteries as well. Yes, huh?
That little circle on top of the vestibulocochlear nucleus, is that part of the nucleus, or is that its own thing? Like the little circle that's on top of the diamond?
Yeah, so the diamond is the vestibular nucleus, and the little circle is the cochlear nucleus. They're associated together, so I just stacked them.
Cool.
Yeah, they're usually one right on top of the other. Any other questions? See where we are? Okay. So, I talked previously about the fact that medial pontine syndrome, specifically left medial pontine syndrome. So we're just going to look at the left side over here. The left medial pontine syndrome is very specific, and it's going to be disruption of these pontine arteries here, and the territory for these pontine arteries is going to be right between, in the middle here, but it's right between the abducens and facial nucleus, so it separates the two of them. And you're going to see some similarities between the medial medullary and medial pontine syndromes. If you look at the affected players, the big difference between the two of them is going to be the cranial nerve that's affected. Medial medullary is going to be cranial nerve 12. Medial pontine, cranial nerve number 6. Okay, that's the big differentiating factor. Okay, so for medial pontine syndrome, cranial nerve number 6 is affected. How's the patient going to present? Yep, their eye is going to be medial. So their left eye is going to be more medial. Okay, because abducens isn't there to pull it out. If medial lemniscus, and medial longitudinal fasciculus is affected with medial, you're going to have a disconjugate gaze. All right, MLF, you'll get a disconjugate gaze. If the medial lemniscus is affected, you're going to get loss of vibration, proprioception, fine touch. The The other thing that's going to be affected here is going to be your corticospinal tract, loss of motor function on one side of the body. Okay, very similar to medial medullary, but just a different cranial nerve thrown in there. It's the same. I talked a little bit about, so that's going to be disruption of the smaller pontine arteries that are coming off the basilar, and that gives it right and left properties. If you have a disruption of the basilar artery in the area of the pons, it's a very specific syndrome, and I'll just mention it. So we'll talk more about it next year in neuro rehab. You'll see presentations of it, actually. Something called locked-in syndrome. Has anyone heard of locked-in syndrome? Yes. What do you know about locked-in syndrome, Sam? They're paralyzed. Paralyzed from the neck down. They can't move anything. The only thing they are cognizant, they are very much aware, they're conscious. A lot of times people with locked-in syndrome can be confused with a person in a coma. The only way they can communicate is by blinking their eyes and looking up or down, okay? Because at the cranial nerve number 3, at the level of the pons, everything else is gone. There's no movement, no communication, no verbal communication, nothing is available to them. But they're conscious, and if you ask them questions, like one of the popular ones would be to look up, they can do it. That's how you know they're in there. Otherwise, they can be confused with a patient in a coma. We'll talk about that difference next year, but just an introduction. For now, you need to know that the pontine arteries here are responsible for left medial pontine syndrome, and patients going to present with these signs and symptoms. Questions? No. Keep on. Pontine left pontine arteries are responsible for medial and medullary syndrome. Yes, the left pontine arteries on the left side. Because if it were just the basilar would get both sides. But those small pontine arteries can give you left medial pontine syndrome. Let's move on to lateral pontine syndrome. Okay, kind of the same players, try and keep the same colors. Yeah, you just want to go ahead and fill everybody in. So green, I think I used, here's your superior cerebellar peduncle here in green. And if I had to make here's my midline for right and left halves. Okay, same thing that we just did. Do you have a question? No? You got it? Do you see what I'm doing? Yes? Okay. So that's just my midline. And now we're doing, let's use, here's my cranial nerve number 6, abducens nucleus. Here's cranial nerve number 7, my facial nucleus. I also had my fourth ventricle. The ventricular system is not affected at all in any of these syndromes. So no hydrocephalus or anything like that. I got your inferior cerebellar peduncle. I did that pink. Okay, so here's your inferior cerebellar peduncle region is in here. Okay. And your middle cerebellar peduncle region. Here. And here is your vestibulocochlear nucleus, vestibular, and then cochlear nucleus. And here in the middle, again, this is your medial longitudinal fasciculus. And your medial lemniscus. Corticospinal tract, always most medial or most ventral. Your spinal nucleus of trigeminal, little C-shaped guy. And your sympathetic tract, or spinothalamic tract, hanging out with your sympathetic tract. Right there, pons, that's everybody. And nothing new, everything we've just seen, just did it again, labeled everybody. And we talked before about the fact that lateral pontine syndrome is due to a disruption of ICA. So here's your basilar artery, and then coming off your basilar artery, I don't know what color I did it. We had ICA coming out as this color here, I think. Okay, coming off right and left half is going to be your ICA. Okay, and ICA's territory is going to be everything lateral of what was involved with medial medullary syndrome. So we're going to have all of this here. And it's going to include signs and symptoms of patients with lateral pontine syndrome. Sorry, that again?
Does it include the
They're all affected, yeah. All the peduncles are affected. So the person's got, since the peduncles are affected, you're going to have a person with ataxia, all right? And since cranial nerve number 7 is affected, what's the big motor function for cranial nerve 7? Facial droop. Patients go present with facial droop. Okay, and you're also going to have spinal nucleus of trigeminal, so you're going to have loss of facial sensation. Spinothalamic tract is affected, so you're going to have loss of pain, crude touch, and temperature. And the sympathetic tract is affected, so you're going to have Horner syndrome. The patient's going to present with all of those things. And this is going to be lateral pontine syndrome. And this is a disruption of ICA. AICA. Okay, with disruption of ICA, it's with, yeah, so just a simple saying that you can remember is with ataxia and facial droop, ICA is pooped. Hope it helps. Okay, any questions about that one? Is that hand, Derek, or you're just,
Yeah.
okay, that's fine. Just checking. Okay, moving on to the last one. Here's medial midbrain syndrome. Then after this one, you guys can work on, you're welcome to work in groups. Talk about contra and ipsilateral for all these patient presentations, which is kind of bringing back the first half and connecting the second half. This has got its own name. Medial midbrain syndrome is known as Weber's syndrome. And as I said previously, and there's no lateral midbrain syndrome, but there's only a medial midbrain syndrome. And medial midbrain syndrome is due to a disruption of basilar and PCA. Okay, so cross section through the midbrain, thinking about the this nice landmark that we have here in the middle, part of the ventricular system that connects the third and fourth ventricles. Anybody remember that one? Yeah, cerebral aqueduct. Good. There's your cerebral aqueduct. Okay, here's that cranial nerve that's involved in most of extraocular eye motions. Which one's that? Yeah, ocular motor, cranial nerve 3. There's the ocular motor nucleus right here. Okay. Again, thinking about this is ventral. It's where the cranial nerves exit, and then this is dorsal. Okay, here, most ventral. Again, we have this is something that has a combined corticospinal and corticobulbar tracts associated with it. Those are your cerebral peduncles. Cerebral peduncles. Okay, here's your tract, disruption of which causes Horner syndrome. So this is your sympathetic tract. Okay, usually somewhere nearby the sympathetic tract, you have your spinal thalamic tract. Again, here's my midline. Bless you. And again, very medial, involved in production of a conjugate gaze, disruption of which causes a disconjugate gaze. It's going to be my medial longitudinal fasciculus. And then another medial structure, part of the DCML pathway. It's going to be your medial lemniscus. And then not really producing any signs and symptoms, but a large structure that's part of the midbrain that we've talked about before. This is your red nucleus. Nothing new yet, just going through labeling some structures that we've talked about previously. And we also talked about coming up the middle, there's going to be a partial disruption of it's either basilar here in the middle or coming off the basilar, said the PCA. Let's see what color that was. I had it in blue. So coming off the basilar, right and left sides, you have going backward, there's your PCA. Disruption of the basilar and or medial portion of the PCA is going to give you Weber syndrome, which is medial midbrain syndrome. The territory for these arteries is going to be here. So you're going to take off a little bit of the cerebral peduncle and then just go straight up medial. So all this region in here is going to be affected. Bless you. So, patient presentation, you're going to have disruption of the corticospinal, corticobulbar tract. Okay, motor weakness, facial weakness, disruption of cranial nerve number 3. If cranial nerve number 3 is knocked out completely, the eye is positioned in a what's called a down and out position, so it's kind of pulled over to the side. Medial longitudinal fasciculus is going to give you a disconjugate gaze. Questions? Midbrain. And these are all those brainstem vascular syndromes you need to be aware of. Going forward, it's something that I'll review or have you review when we get to the down next year, but oftentimes they are as part of the board's exam. I will